Our next speaker is Dr. Prem Kandiah, is one of our neuro and surgical critical care attendings at Emory University Hospital. He'll be doing the one-man pro-con debate on ketamine in the ICU.
Good morning. Good afternoon, everyone. I'd like to thank the organizers for inviting me to do this debate today. I could start off to tell you honestly, I suck at debates. If you ask my wife sitting right here, she wins all the arguments. I end up grunting and walking out of the room. So, but today my opponent, though, is hailing from a parallel universe, is an intensivist who hates ketamine. So thankfully, he's a worse debater than I am. So ketamine is useful and safe adjunct for continuous sedation in the ICU. So I broke it down, so I'm just going to cover the desirable features of ketamine sedation. So you have consistency of providing analgo-sedation, so good hemodynamic profile, bronchodilation, minimal respiratory depression, protective for depression and so anti-suicidal effects, anti-seizure, anti-emetic, anti-shivering, safe in head injury, and tolerable psychomimetic effects. I'm going to just breeze over this, but the predominant hypnotic effect of ketamine comes from the blockade of NMDA. And kind of like if you compare it to propofol has both NMDA blockade and GABA blockade, well, benzos have GABA blockade. Ketamine, you can think of it as a spectrum, it's predominantly on the NMDA blockade. But beyond that, ketamine is actually a very dirty drug. It functions on many receptors, more than 20 receptors. And that's how everyone has these magical claims about ketamine. There's hypnosis, there's psychomimesis, there's analgesia, antidepressants. And different people can react differently to ketamine because if you have an upregulated receptor and one of these set of receptors are upregulated, then they're going to have a manifest slightly differently. If you give ketamine to someone who is a polypharmacy drug addict, you'll see a very, much violent reaction compared to someone who's naive to a lot of opioids, for instance. So, ketamine analgo-sedation. We moved towards A1 sedation. We all have, benzodiazepines is a bad word in the ICU these days. But as an intensivist, as people who work in the ICU, you're kind of cornered with your options right now. You have propofol and you have fentanyl, and you're kind of stuck with these two things. Then you throw in the dexmedetomidine when you can. That's pretty much it. So ketamine offers a nice addition to help augment some of the sedation. It works through some of the analgesia effects are through the mu delta kappa receptors. There's a muscarinic central effect, and there's also a peripheral effect to sodium channels. But what about ketamine? Ketamine is, we all know this part of it. The pain services often use ketamine to augment pain management in post-surgical patients. And it's very effective. There are studies to justify it. It certainly reduces the amount of opioids you need to treat a patient significantly. So when we talk about ketamine, what if you compare ketamine to other sedatives? If you look at benzodiazepines, ketamine, as I said, does not affect GABA or minimally affects GABA. There's some papers out there suggesting that it does have some indirect effects on GABA. And then it provides an alternate to propofol because you're stuck with short durations of propofol before you have to think about, have to follow your triglyceride levels. So it allows you to transition off propofol. And then you're likely, it provides analgesia in comparison to dexmedetomidine. So how many of us have tried dex hoping that'll work, and then the heart rate drops into the 20s, and then you're kind of like, let's scrap it, and then you're stuck with what you use, right? And that's where the ketamine kind of comes in nicely because it has that, it has the opposite effect on the heart rate. So the big reason a lot of people want to use ketamine is the favorable hemodynamic profile, right? It's less hypotension when compared to propofol. Absence of bradycardia when seen with DEX. It increases cardiac output in healthy volunteers. That's by 40 to 50% at blood concentrations in the therapeutic range. And its postulated mechanism of cardiac output is indirect mechanism. It blocks reuptake of catecholamines in the presynaptic clefts. So so that you get more of a sympathomimetic effect. There's one study that suggests that there's a direct effect on myocytes, but there's also opposing studies on that. And then the other reason is bronchodilators. The ER docs love to use ketamine to help manage asthmatics and COPDs, at least transition them, prevent intubation. There's bronchodilating effects of ketamine, which is great. And there are three mechanisms, again, through sympathomimetic bronchodilation, and there's bronchial smooth muscles, anticholinergic through anticholinergic effects, and then there's anti-inflammatory effects as well. And the studies are small for ketamine in status asthmaticus, but the majority of them are case reports and a couple of case series, but all of them point towards improvement in when used to manage severe asthmatics. And then another advantage is minimal respiratory depression. We don't have too many sedatives that you can have someone on the ventilator and then technically extubate them on it and continue it afterwards. At our hospital, we don't do that because the policy issues related to running ketamine in an unintubated patient. But it has minimal respiratory depression. You're able to at least keep not have to stop the analgesia right away, and the transition to pain control is a lot better that way. So then it allows for spontaneous breathing trials because they actually there's minimal respiratory depression. It's not your lungs are still sensitive to carbon dioxide, so your rates does increase. You don't become hypercapnic on therapeutic doses or lower doses of the ketamine at least, and obviously the bronchodilatory effect if you have a COPD on the ventilator and you're trying to transition him. These are a couple of the you can study these, but these are the scenarios where I love to use ketamine. There's the COPD on the left who you're trying to extubate from vent to and you want to kind of maintain you want to be able to make sure that it tolerates the BiPAP. It's not going to rip it off and throw it away. So he has some anxiolytic component. It has some analgesic component, and some bronchodilatory component. How many of you all see trauma patients? Trauma. What happens when you have a patient with a bad rib fracture that gets intubated? Most of the time, they end up getting trached. Right? So it's a very you think it's just a rib fracture, but it often goes south once you miss the window of trying to keep them from being intubated. You get a refusion, you get atelectasis, you get pneumonia, they get intubated, they get agitated, and it's like a vicious cycle. So trying not to intubate them is the goal. So that's where ketamine comes in really nicely. You can alternate. You get analgesia. These are the ones that you have to keep them well expanded with non-invasive ventilation for days, weeks sometimes. And if you can ride them through that, they actually do really, really well. And so this is where it's helpful to have ketamine because you're not just banking on your opioids to control pain. And then we're talking about other causes of splinting, your chest tube splinting, and your abdominal splinting. All of these provide you analgesia that you can transition technically from a ventilator to an extubated state, right? And not have to stop everything and start a PCA and then have this uncontrolled pain that causes you to splint, and you get back into this vicious cycle of atelectasis, desaturation, reintubation, right? That's what you're trying to. All right. Then there's protective effects. I'm going to glance over this though, but there are a number of studies that showed the short-term response in bipolar depression and suicidality with ketamine. And there's also PTSD, response to PTSD with ketamine. At 7 days, there was a significant improvement in PTSD. Now, we all think about the big buzzword now is the post-ICU syndrome, and PTSD is one of the big features of it. You know, ketamine may have some positive effects on it. It has not been studied, but if it helps PTSD in this scenario, it may be beneficial. What about ICP? How many of you will intubate someone with high ICPs with ketamine? How many won't? No. All right, so the studies that say that ICP issues with ketamine came from 1960s. Actually, this was one in 1972. There was 3 series of studies. They were done in adults with and kids with VP shunts. When they went to OR, they intubated them, and if you see here, all but 2 or 3 of them had really high ICPs right after they got a dose of ketamine. But and that's something my opponent is going to harp on after. But if you look at all the modern day studies, right? There are multiple TBI studies, brain trauma studies. All of that have shown no issues with ICP, and there's no change in ICP. In fact, there were studies that showed ICP went down when you're trying to suction someone and you pre-treated them with ketamine. And again, there's a theory to it, and we'll come to that in a little bit. But in effect, that most places now have stated that they've debunked this myth that ketamine can be used in ICP. So it's not it's used regularly in intubation of TBI patients now. What about ketamine and alcohol withdrawal? Once you intubate someone with alcohol withdrawal, propofol works really well, right? But you can't run it for too long. And part of the reason it works well is, again, it has NMDA and it has GABA, right? So if you use, the theory is if you use ketamine on a patient with alcohol withdrawal, now you're tackling NMDA and you're getting your benzos for your CWA protocol. So you're actually attacking both molecules, almost like running ketamine almost like running propofol on an unintubated patient. So in this study, they started ketamine in a patient, and they immediately brought down the dose of benzos required by 40 milligrams in the first 12 hours and then subsequent 13 hours. So there's only one case series that we can't really mimic yet. So back to just to close up, these are again the desirable features. The ones below, there are studies that show anti-seizure effects. We use it for status, anti-emetics, anti-shivering, and tolerable. And people pay a lot of money to go on psychedelic trips. I mean, I don't know why we dumped the drug for 40 years just because the people were having trips in the hospitals. You think in the 60s people would have hung on to the drug for the reason alone. But all right, next. Greetings. I hail from a parallel universe. I'm one of few intensivists. It's conceivable that I actually hate ketamine, but I'm a better debater than my opponent here from your universe, right? So, these are my list of undesirable qualities of ketamine. This is why ketamine should not be used and is not safe in the ICU. You have emergence delirium, you have tachycardia, tachyarrhythmias, myocardial depression, intracranial pressure elevation, which, while people think it's debunked, there is a significant component that's often missed, and I will touch on that. Siluria, laryngospasm, inadequate respiratory control. All right, so emergence delirium. I know my opponent here thinks it's not an issue. But it was reported in 1965 to initially reported as having strange feelings and not a feeling of floating and not being able to feel your body, and that's where the word dissociation came from. there are many drug trials in ketamine, and they have a good number of patients who pull out of these trials because they don't like the feeling of being on ketamine. So yes, it is troublesome to a significant number of people. Anyone ever seen an emergence reaction from ketamine? Yeah, so if you don't recognize it, it's a problem, and that's what the fear of using in ICU. If you see one of these, you'll know that their eyes will open up wide, and then they start shaking your hands. You see that one? No? Yeah. And some people mistake it as shivering. They give them more ketamine, right? So you need to know what the emergency reaction you're looking for. The guy with a tube in the throat is not going to tell you, I'm hallucinating, I'm seeing stuff. You know, that's not going to happen, right? In systematic review of ketamine trials, the rate of hallucination was 7.4% compared to 3.7%. This was although just procedural doses. And then there was one, they had nightmares, 2.4%. But really, my opponent here would state that the dreams were more than the nightmares. It was 18.2% who had good dreams with ketamine. So what about psychomimetic effects? You be careful of who you pick with ketamine, right? So, and I had seen this before, patients with psychiatric disorders, and you know, it's hard to throw them all into one pocket, but they tend to, I had a bipolar patient, for instance, who really did not like ketamine. He really went ballistic on ketamine. So the psychomimetic effects do affect some people more than others, and it's partly because of the multiple psych meds on upregulation of certain receptors. There are 20 receptors in there, and that's affected by ketamine. So it's a very variable response, and it's very unpredictable, right? Role of benzodiazepines to mitigate. So when you give ketamine in the emergency department, you're mitigating the effects of emergent delirium by giving them what simultaneously? Anyone? You're supposed to always give ketamine with benzos, right? Yet we're not supposed to give benzos in A1 sedation, ANALGO-SEDATION. What may end up happening is now you have a patient running completely on ketamine and nothing else. Because they've weaned everything else and you're left on ketamine. So that's why if the patient's tolerating it and is doing fine, it's great. But if they're not, they may be tripping the entire time and no one's noticing it, right? So that's where we have to find a way of being able to capture the emergence reaction. And I always say if the person's maintaining on ketamine, you need to go and talk to them. You need to tell them, the stuff you see in the room is not real, right? It's part of the drug. And I do that. I tell them that. And you can actually, to go one step further, you can manipulate it. You can actually enjoy it and have fun. And afterwards, a good number of these people will start chilling, and you can see them, nodding around and smiling. They realize that they have control over it. It's not controlling them. So, yeah. But not all of them. Some people, What about tachycardia, tachyarrhythmias? In multiple trials, ketamine just raises your heart rate because of the simple mimetic effect. The AFib patient that gets flipping in and out, you've stopped amio 5 times, it goes back into AFib, and maybe it's the ketamine that's running in it. And there is about a 7%, up to 7% risk of AFib associated with ketamine. And it gets forgotten, and I just had one patient with recurrent AFib on it. It's not the predominant cause, obviously, but it does tend to push someone into RVR. So back to this diagram. So if you see this chart, you see these two people here. They had functioning shunts, and the rest of them did not have functioning shunts. They had EVDs. So remember, the brain's like a sink. You're making CSF, you're draining CSF at a fixed rate. You're not draining it, you get hydrocephalus, right? And so these people had hydrocephalus. They went into the OR and they clamped their EVD so it didn't spill out. And they gave them ketamine, and their ICPs jacked up real fast, right? If you think about the Monroe-Kelly doctrine, this is fixed space, brain, CSF, blood. if there's increase in mass in one, the other one has to compensate. So if your CSF cannot be absorbed and you've clamped the tube, there's no way to compensate, right? And that's why those patients, and ketamine is known to increase perfusion to the brain. So you actually increase the perfusion component, and there's nowhere for you to compensate. You can't use your CSF to compensate in this way. And that I think is why a lot of those patients had really high ICPs. And the two people that had functioning shunts, they didn't have that problem. So yes, most TBI patients don't present with hydrocephalus. You can probably use ketamine and intubate them. But what about that subarachnoid hemorrhage patient who is now in brink of hydrocephalus, swollen, and doesn't have an EVD, gets flown to your and you wanna intubate this patient? And this is the scenario where you don't want to use ketamine, right? You induce them with ketamine, the ICP goes up, you just push them over the edge into herniation, right? So for the most part, it does not cause ICP elevation, but when you have non-obstructive hydrocephalus or really bad hydrocephalus, those are the patients that you don't want to use it. So, and a lot of times you may not have a scan, then you wouldn't want to use it anyway, right? Yeah. The hemodynamic effects of ketamine, there is one study that showed a negative inotropic effect when they ex vivo, when they took a piece of muscle and they smeared it with ketamine. And this is one of the other worrisome things. We always think of ketamine being a safe drug in a patient with shock. But remember, your balance, the reason why your balance is because you've upped all your norapi, your catecholamines, and you have a little bit of myocardial depression, but the net result is you still have increased perfusion, you get increased output because your catecholamines are still proportionate. The response to catecholamines is still higher than to your negative inotrope effect. So what happens is if you have someone who's depleted of catecholamines, a chronic, subacutely sick person, for days has been inflamed, and finally you intubate that person, they're going to be depleted of catecholamines, and they're the ones that crash when you intubate. So don't assume everyone that you intubate with ketamine is going to have normal blood pressure. You want to know what their preceding illness is, how long have they been really sick. So in the study by Miller et al., they separated this group of patients by a shock index. They divided heart rate by systolic blood pressure, and it was more than 0.9 that was high, less than 0.9 that was low, and there was a high hypotension when your shock index was really high. So if you have really bad shock, ketamine may not be the drug you want to do, right? And it's going to converse to what we always thought. But for the most part, you'll get by because there was only a 26% that became hypotensive. But you will hit that one that will crash when you get ketamine because of the negative inotropic effect. So the other adverse effects, sialuria, bronchuria. How many people have intubated someone on ketamine? Was it easy? Yeah, exactly. So if you don't do that, so the classic scenario is they go on ketamine for days, they have so much of oral secretions, the tube's like slipping around and the tube slides out. Then you imagine trying to intubate it. If you don't have time to dry them, your max scope sliding all over their mouth, trying to get the tongue up, you end up having to use gauze to pull the tongue up to get it out of the way because it's just very slick and very slippery. So you want to know that it's not a big problem, but it does inhibit. So you can use things like glycopyrrolate to try and dry oral secretions, but then you run the risk of drying up pulmonary secretions and getting mucus plugs. So it's a catch-22 situation there, right? Laryngospasm, it's very low incidence, usually related to boluses, and it's currently unclear who gets it, and it's not. They say you can reposition the head and it goes away, but it's still a scary thing to have an unintubated patient with ketamine. Obviously, you don't use ketamine it doesn't give you a lot of respiratory control. Have you seen misuse? Someone is desynchronous and then they go, let's start ketamine, but it's not going to do anything for to get you respiratory control. You're not going to get a synchrony you want. And And the last thing is the ketamine addicts, they've noted to have this ulcerative cystitis, really damaged bladders, and then they also can get cerebral atrophy. We haven't seen that. The atrophy is one case report from way back, but from a patient from long-term ketamine infusion. But since then, we haven't seen a case that has developed in the hospital. So we're not really sure with this recreational use versus hospital use, is there a difference between the two? So to summarize, the main undesirable qualities, we've covered most of these. Yes, intracranial pressure, you need to select for, you definitely don't want to use it in hydrocephalus patients, but you can use it in most other TBI or brain injured patients. A summary. So the summary, in interest of time, I can't have two people summarizing this, so we'll get a third person from another parallel universe who's a little bit more neutral. And so ketamine has desirable effects, and we're kind of limited in what we can use to sedate people. So having ketamine does help very specific scenarios, but it requires further investigations for some of these unknown factors that I mentioned. But at the same time, you need to know about the myths. There's a lot of hype with ketamine. If you tweet ketamine or you Google foam ketamine, there's like discussions on the web for days about ketamine. So you do want to separate what the hype from reality, because at one go, everyone assumed there wasn't a neurological problem at all with ketamine, which wasn't completely true. And then, so how do I use it? So I avoid it in hydrocephalus. If you have someone who's chronically ill who then crumps, like one of my cirrhotics who've been ill for 2 weeks and with vasopressors and then loses their airway, if I use ketamine, it's going to be very, very low. I mix it with something else. It's not something I want to go full dose and then drop their pressures in the process. Because it's a gamble. You don't want to know you don't know when you're going to get that 26% patients that are going to have that negative inotropy. If they are recurrent AFib that's hard to control, I keep them off the ketamine because that's only going to push them over the edge. Pre-existing psychiatric illness, definitely no ketamine after my escapade with that one patient. Do explain, as I said, do explain to the patient about the hallucinations, tell them they're not real. And then assess, so if you're running ketamine, look for psychomimetic pictures, look for that shaking, that wide-eyed glare, the staring across the room. You need to kind of pick that out. If you don't pick that out, you won't recognize it, and they'll be tripping for days, and we don't know what the effects are down the road. If not intubated on ketamine, and they start having noisy breathing, there is that small percentage of patients, is like less than 2% of laryngospasm. So you don't want to ignore it. Chances are you'll never see it. It's usually in bolus dosing. But if you come across that, you don't want to ignore the noisy breathing. Make sure it's not truly snoring. That's it. Thank you.